We can also assess pressure half-time. This also is a level 1 recommendation when assessing mitral stenosis severity. The actual formula here is the mitral valve area is 220 divided by the pressure half-time. This is validated for rheumatic mitral stenosis patients, not calcific mitral stenosis patients, and we'll talk about why that's important here. The way this is performed is using continuous wave Doppler and tracing the deceleration slope of the E wave on the Doppler spectral display of the transmitral flow, and it'll measure the time at which the peak pressure becomes the half pressure, essentially the pressure half-time. And a way to remember this is that the longer blood takes to flow through a valve, because it's more stenotic, the longer and greater the pressure half-time will be. So increased pressure half-time is a lower mitral valve area. Lower pressure half-time would indicate a higher mitral valve area and less severity. There's a few confounders to be aware of when using pressure half-time in your assessment. Severe aortic insufficiency can increase your LV filling rate, as both the mitral valve and the aortic valve will fill that LV cavity, causing premature mitral valve closure. Mild to moderate AI really shouldn't significantly affect pressure half-time, but severe AI will play a factor here and can give you inaccurate measurements. Impaired LV diastolic function leads to the lower reliability in elderly patients. This is why it's frequently not used for degenerative mitral stenosis evaluation. And I'll quote this directly from the guidelines: the use of pressure half-time in degenerative calcific mitral stenosis should be avoided. Sometimes you will have this bimodal distribution of the deceleration slope of the transmitral inflow. Remember, trace the slope in mid-diastole rather than that early deceleration slope. That's how you're going to get accurate measurements. Trace the middle part of that E wave.